that's important is because I feel we need to be very cognizant that the AI is enabling so much in precision payments and in precision medicine, but the risks are very real as well. And so it's nice to talk about some of the examples of where this is at. And thank you for inviting me to do so today.
Oh, well, thank you for joining us, Demitri. And as you mentioned, you need that bulk of data in order to do real work. And we were just on another weedy artificial intelligence 2-hour session where that was, we were talking about generative AI and the new stuff. So hopefully you'll get into some of that. But without large amounts of data, there could be lots of problems. So I'd like to keep this in the context, hopefully, of the weedy letter to Congress that just dropped on Friday. So if we could maybe address the first critical issue, which was related to AI and the patient experience. So Weedy stated that plans are using AI in cost calculations by using historical claims data of what the services cost. Can you, I think if you could, some of these slides, let's see the AI drivers. So maybe, yeah, if you can work on this, I believe this is where payment model would be episodes of care. I'll turn it over to you, but if you can keep it in the context of the Weedy letter as far as how the patient's experience and then provider, what problems we're solving with AI, which historically episodes of care or payment bundles really didn't do well.
Definitely, and I would also like to keep this conversational. So as I'm talking and we're doing this interview, Micah, if you have any questions, please raise them, and comments for sure. Right. When we're talking about the patient experience, there's a lot of places AI is sort of known in the industry for precision medicine that comes in. They're reading and diagnosing cancer, cancerous tumors from radiology scans, the sort of things that you see on the news. But the fact of the matter is AI is everywhere and it's affecting the patient experience in very profound ways. One of which is the entire view of value-based care and looking at alternative payment models. That is really towards that triple aim of and trying to drive down the cost while increasing that patient experience. In driving down the cost, all these models started coming into very particular situational areas where, say, for episodes of care, you needed to know what cost mattered towards that episode. You needed to know what was the patient's health coming into that episode. All of a sudden, these payment models, while very powerful and profound and positively impacting the patient experience, we're creating a lot of risk and worry in the providers. And so while there are these wonderful value-based care models that are being adopted, it's been slow, it's been messy, and it's been coming with a lot of setbacks. And so where AI is starting to come into play and how it's going to affect the patient experience is that it's going to make that more seamless. A lot of those issues that whenever you are dealing with a situation which require a lot of individualized personal decisions of what was your individual health experience in the past, what was the cost exclusions of this particular episode. When you get away from that statistical view, that's where AI really comes in and shines. And that's where you'll typically see AI used in other industries. For example, recommending you a song or recommending you what to buy next. So now that they're applying this, and it's not theoretical, this has happened across our industry. AI is now in the space of making payments, and it's in the space of making payments on value-based care. But we need to be careful. This is, in my view, the door, because I'm seeing now in the industry that jump from value-based to fee-for-service and everywhere else from the successes we've made on the value-based care side. And so now looking directly at the slide, in episodes of care, which is one of the higher land categories, you really have this two-sided risk that we're really trying to get to of you have an episode, say a perinatal episode where you're looking at a pregnancy in the postpartum period, you run it over that period and you judge the provider over that entire period. The cost for that entire period, the quality of that entire period. Well, having a commendable threshold that you want them to get below, or having an unacceptable threshold where you're going to require that sort of shared losses is a very difficult sell to the providers, because they will always come back with, well, you didn't consider my individual patient's issues. My patient had diabetes. My patient had a COPD. There were problems that were involved that drove up the costs. And so the answer in the industry has been, we're going to statistically model this and address that with statistical models, but that has not sold yet in the industry as well. There's still challenges that we have seen talking to our clients, talking to industry leaders in episode of care, where that still did not make providers feel comfortable enough to enter into these arrangements, even though based on a lot of the metrics we were seeing in research, and especially, you know, from government places like TennCare that had put forth these, the patient benefits were major, they were huge. So being able to get down and dive deeper into all the granularity of those, not just the conditions, the chronic conditions, but also the demographics in the patient's history became paramount. Statistical modeling was going to start, it just starts to fail at this point. And
Yeah.
could you go to the next slide, Mike? Because that's the
Yeah.
real issue. You need
Yeah, can I
AI.
just, yeah, you
Oh,
mentioned
yeah.
TennCare, and they were very progressive years and years ago to push out waves and waves of episodes of care of payment bundles, including, I think, the first wave had perinatal. And they had a lot of pushback from the providers saying exactly what you just explained. So are you saying this statistical model is able to, you know, really fairly assess each episode and say and you know, compensate the provider correctly based on all those factors that you named before? Is that what the new AI is driving that down to a member's adjusted risk, not just, you know, you get paid $20,000 for every pregnancy, and that's just not fair. That's why the providers push back. Is that what you're saying?
That is exactly what I'm saying. It's that same view that used to be when you tried to do a search or you went to, you know, Pandora, you tried to get some music and it wasn't personalized to you, it was statistical. They had, you know, people like this, so they probably, you will also probably like this. It's all changed. In those industries, you go there, it knows you, it knows your history, it knows what your claim date is, it knows specific things about you. In the healthcare space, obviously, it knows about your music in the you know, music space, and it makes the recommendations now directly tailored to you, usually using a set of algorithms that we don't fully understand. It's very
Exactly.
powerful. We statistically know it's great, but yeah, we don't know every decision. And I'll talk a bit about that because that was the second question you had. That's getting better as well. But
Okay.
now you can get directly down to that member level. And that's exactly what AI enables. It can go and look at each individual and say, this is exactly what you had. This is exactly what that means. For you individually, here's what we predict.
Okay, thanks. I guess I jumped the question. Looks like your next slide is going to explain that. Thank you.
No, but that was a fantastic question, and that's exactly this. So, thank you for the lead in. And if you go forward, there's sort of two examples here. And I just want to point out a couple pieces, and these are individual examples of, say, a risk adjustment inside an episode of care. Specifically, these are both oncology episodes of care. And what I want to show is just in this one product slide, all the personalization that now exists inside a payment model. So for the first example, we have a 48-year-old woman from North Dakota in a group plan, has unfortunately T-cell lymphoma and is managing epilepsy and unfortunately developed COVID-19. And I want to point out all those conditions, which you'd normally expect are removed and accounted for, but we're also accounting for where they're at. So it's a group plan. And below, you're going to see some differences when we look at what happens when you go to a government plan. It cares about where it's at. So now we adjust and understand what North Dakota means to it. We understand what the age means to it. As SDOH features start becoming more and more prevalent and captured in the data, they're going to start funneling in more and more into these decisions as well. But the only way you can calibrate this and say that this is a 48-year-old woman from North Dakota, therefore, I think the risk score for pneumonia is 0.752 versus, or more specifically, sorry, epilepsy is 0.0577, whereas in the second example, you have a 72-year-old man from New Mexico on a government plan, and we give a higher score of 0.1965 for that risk value. That personalization all comes from the AI on the underside, making those decisions, looking at not just the statistics of it and the aggregates, but looking at deep individually into the past data to understand what those patterns are.
Yeah, and it's interesting that you put the two types of plans, because the new model with CMMI pushing for states to sign up for that, states advancing ahead, they're trying to make it all payer, and I think that they're gonna run head first into you know, the different types of plans and people and such like that. So interesting. Do you want me to move to the next slide?
Yeah, definitely. And just to give and this slide was only to give a view of just that this is comprehensive, this is live, this is complex, and this is sort of what you will see throughout the industry. It's not just one or two pieces. It's taking all the client data, combining all the data together, because you have to, you know, the claims data, the enrollment data, as we're going to be seeing in other payment models, we have government data and public data, putting that all together, generating out fairly complex architectures and doing fairly complex model training to get to now decisions to allow us to do precision payments. And having those precision payments, I mean, is a very net positive in my view for the industry, because it allows us to bring all these benefits to the payers and to the providers and to the plans. But there are risks, and I believe you have a question coming up next that is a great segue to, which is talking about some of the risks that the WEDI letter also very clearly mentioned. And
Yeah, no,
explicit.
I'd love to keep it, focused on the WEDI letter to Congress, because, jumping up to, the third critical issue that WEDI addressed was, the challenges with the data, right? So, the data that we're leveraging for AI and that potential for bias. So WEDI's recommending that end users, both the patients and the providers, be provided with this transparency, like given a type of I think we said nutrition card, or maybe a nutrition label, right? So it informs you of the underlying data that is being used. And I've heard you many times reference the importance of transparency in models, algorithms, and the data used. So we don't want to have that black box with no traceability, no accountability. So maybe is that what you're gonna do?
Yeah,
with
that would.
the slide? The
That's
slide is
exactly.
painful to look at, but
Not this slide. This slide was really just to put
okay.
forth that this is complex, that what we're doing uses all the data, advanced algorithms. It really is meant to just showcase that AI is here, and because it's complex, we don't, we got to be careful on how we understand it, which is exactly this lead in, which is that nutrition card, the ability to know what's inside of it. And I want to take a second just to address these ideas that are being proposed to Congress. And something that I and the Senate that I really liked about the WEDI letter is generative AI is where people are talking about having those nutritional cards typically. So if you hear like the Elias Escobar talking about it from the chief scientist from OpenAI, the makers of ChatGPT, or the CEO of Anthropic, Dario, they've directly called for this as well, but they've called for it in the understanding of the data going into these big models. But something I think that WEDI called out, and is very important, is it's not just the big fancy models like ChatGPT or your DALL-E or your Stable Diffusions that you want to have a better understanding of. All the models that are making decisions, especially around how we treat patients and decisions around protected classes in general, really need to have that same level of scrutiny, even if they're all not generative systems. They're sort of the standard, more historical ML systems. And so with that context in mind, I want to talk about, even in those systems, why it's important to understand bias and transparency, not just the systems that are providing us chat answers, but the systems that are doing payment models and risk adjustments. And in this case that I want to show you, a provider ranking example. And so this is another example that I'm going to go very quickly over, because I want to keep it towards the bias and transparency, but to make sure you understand what this is really trying to get at, and the need and requirement for transparency in this is really a hope of understanding provider performance at a holistic level. And that is, I know, a very loaded, historical, and a challenging issue that's been in the healthcare industry for a very long time. And to try to make a claim at that is only one that we could do because of how far AI has come. And we know that because if we're trying to say how well a provider performed on a patient, the first question is, what do you mean by how well? Do you mean cost of care? Do you mean quality? Do you mean utilization? These usually conflict, and there's issues between them. But once you dig one click deeper and you say not just how well, but how do we know that we're doing it correctly? Now you got questions of, well, what if they have different specialties? What if they have different underlying risk scores of their patients? What if they're in different demographical regions? And all of this starts coming in, and it becomes complex. And it becomes so complex that, if you start thinking about it, you start feeling exhausted. But this is where AI shines again. These are all individual decisions that need to be made for each person based on their exact history, each provider based on the patients and their history of costs that they've been seeing. That requires this AI. And so with this use case in mind, I want to talk about then why it would be so important to have bias and transparency. I think transparency is clear. If you're going to tell a provider they're doing incorrectly on something, it's important to back it up, both so that, one, you engage them and they agree with you, but two, you offer them solutions and help them move it forward. So if they have a challenge, they're facing it. And if they're doing something great, they know how to lean into it and make that flywheel spin faster. So we need transparency, but bias is also very scary. And so when we start talking about holistic systems, because bias can be easy to miss. And so with that, can we go to the next slide, Mike? Actually, we're going to jump this one and go to the next one, because I really want to focus this on the bias. And I'll just say, for the way our system works, we will look at all the individual measures and aggregate them later. I'm going to give an example of what it looks like when you look at a particular measure. So it's a cost of care benchmark, specifically medical cost PY. for a provider. And the need is when we say you're, the 50th percentile or the 90th percentile in cost. We want to be able to justify that. And so in our models, there's been a lot of changes that have been happening in the last 2 years that have really taken us from being able to do this with black box models to what we are now calling glass box models. And so on the left, I want to show you that in this very large space where we have specialties, we know the FIPS code of the region, the BLS's quarterly census of employment and wages, the competitors they have in the region, the poverty rates, and the getting hundreds of all these different pieces around that provider together and making a decision was the first step. But then going back, we can now go back and say, this is why. And it's not just, this is how important it is. Explainable modeling, while new, is showing to get close to as powerful as regular AI modeling. But when we look at that feature impact graph above on the left, the way you figure out the prediction is not, oh, that's how important those are. You just added those values together and you get the prediction for the cost of care. And so you now know directly, based upon their specialty, that was this much that we expected their cost of care go up. But they're in this region, so it went down. Also in this region, we know the QEC value is low, so we're going to make that go down. And as you can look down that list, we have that for all 100 features. We know exactly what caused our prediction of how much we thought their cost of care should be. This is new. It's only 2 years old, but it's important for that traceability. And so those are very promising things, but they need to be adopted. And it has to be an intentional decision by those of us in AI making these models. But that's something that I think the industry helps with, because as the demand for this increases, so will the supply. The AI models in healthcare will become this. So as we require nutritional labels, as we require this explainability, all these advancements we've seen in the last 2 years are going to just explode into this wonderful understanding of what's going on in these AI decisions in our healthcare. But I'm going to take a pause there, Mike, and ask if you have any questions or follow-up before I talk about the bias side.
Yeah, I'll open it up to work group members or any questions on this. My brain's hurting, but it's just like you said, it's going so fast. And if we don't address it, we're going to be, looking retrospectively on how we can fix it. So I think that's really why Weedy was really strong and sent that letter to Congress. So any questions from the membership? Just speak up now. Otherwise, hey, I'd love to know more about the bias such, because, I've been with our clients and we always speak to, the bias within our models and stuff, but, are we going to be solving, as you mentioned earlier, with some of the social determinants of health, collection of data, do we have any capabilities there that, the industry can, start to, because if you look at all the new models coming out of CMMI, they all have that health equity piece where you have to have a health equity plan and you have to show that. There's all types of statistical models that are trying to, add into that and also then get down to the member levels. Is there anything you can address on that type of a bias?
Definitely. And I want to say bias is a loaded word when we talk about modeling, because there is, but what it really means is there's something going on in the population that's truly happening. And your model is, for whatever reason, choosing some other value consistently that doesn't account for that. Like having error is okay in a model. All models that we ever build, and we know this from our payment models, will always be up and down. But on the whole, we expect on average, you have about as many misses going high as you did low. Bias is when you really start missing in one direction. And the reason that matters and why we use in all of these is because when you now think about how that affects protected classes or minorities or underprivileged populations, now all of a sudden those decisions have real world and potentially disastrous consequences. And so there has been a need in the industry. And part of the slide's real use to me, outside of just showing we can do this, is to put those names down: Cornell, Microsoft, IBM. It's the speed at which this is moving in the last 2 years has been phenomenal to watch. We've identified the challenge. There are packages out there across the industry now that help with this. And this is something important to remember about research in AI that's a bit different than, say, traditional research in medicine or other fields, is that when a result is published in the AI space, the time from that result to adoption is usually now in the matter of days, not the matter of weeks or months. And so as these models come out and IBM puts out AI fairness, and we have now these new metrics, and I'm going to sort of talk about that a little bit in detail here in a second, so we understand sort of what they look like. They're coming out and this research is happening now. Everything I'm showing you is 2 years old or younger. This didn't exist back in 2020. And so these are things that if they didn't exist for us in the industry, I want to make sure that you now know they exist for all of us and that we should be demanding them. And so we'll get into the metrics and fairness on that, but that need that you mentioned is there, and the ability to reach it, and that's the real purpose of this, is I want to show you we can do it. The industry is ready. We're not ready to do everything. We can't explain why an LLM makes a decision. We can't explain why ChatGPT made a decision. We can't explain, but we're ready to tell if you have bias in a model. And so let me give you one example of this. There's a set of these different metrics, but disparate impact ratio is an easy one. So you look at the favorable outcomes for the privileged class versus the underprivileged class, and you see what the ratio of those are. So if you're looking at, say, predicting cost of care, when you look at the male providers, what is the favorable ratio, the lower cost of care predictions coming out of them as opposed to the female providers? And we can quantify that. And if you look above, this is an example of one of our test models. We saw a 1.12 ratio. And what that means, any value over 1 means you're predicting higher costs for that group, which meant as we're looking at our models are predicting higher costs for male providers than female providers. That's a bias issue that we've now identified and need to go address. This is the way in which we can do it. We can't explain every decision, but we can detect when something's wrong. And that at least is a very good first step. And then if you're using the right type of models, like the explainable modeling from Interpret ML on the left that was generated by Cornell and Microsoft back in 2021, you have now the ability to go down to every individual and figure out how to address that. What of these features was causing that? Can we change the historical data and find what was creating this bias in? Because one thing I think I didn't explicitly say, but we all understand that the reason bias exists in these models is it's a garbage in, garbage out. If there was bias in the historical data, the model will pick it up. So hopefully that makes sense, that the industry is there. We can do this, and we should. And this is what I'm happy to see from Weedy. We should demand it.
Yeah, no, that was great. Maybe we can jump to the fifth critical issue that Weedy addressed in their 12-page letter. We actually made 20 recommendations, right? And obviously they all pertain to recommended federal government involvement in AI and policy development. Do you have any thoughts or comments on the 20? I know I just sent it to you over the weekend, but where do you see regulation is going to have the most immediate positive impact? Just your opinion. We won't hold you to it.
I appreciate that. I've thought about this a lot lately because I've been in this space and deeply in this space, and it's a space I love dearly, and it's exploded ever since ChatGPT has come out. The space and the research in the space is moving fast, and I'm showing you things that happened in the last 2 years. Mike, if you go to my last slide, I just want to point out 4 things that happened this year that surprised me and the entire industry. Should surprise you. The speed is accelerating, and I think it's important for us in the recommendations to keep in mind that the speed is accelerating, because this is going to really flavor my comments as to what I felt about the recommendations and in general what I'm worried about as we go into this regulatory environment. So I just want to look at the bottom of this first. Things that have happened just this year. It used to be very difficult to get AI agents to basically give them a goal and have them figure out the tasks and execute them to get it done. That's solved. Turns out ChatGPT can solve that by just asking it to do it in the right way. And so AI agents now exist, which didn't exist last year, that can go out and do things. And they're not perfect, and there's a lot of issues with them, but they can play Minecraft, they can research, they can papers for you, they can make decisions for you with a limited set of skills and act sort of like almost an adaptable intelligence inside of a system. That's a new area that over the next 5 years, we're all going to be figuring out what that means for us, because there's limitations we don't know about. There's a lot of promise, and there's a lot of potential, but there needs to be a lot of guarding around that. That I'd say to me is the biggest one that woke me up to what's happening. But other things that happened as we're training and trying to figure out how well you can sort of pass the bar or an AP calculus exam with ChatGPT, Google found out that if you just intentionally teach it how to think on how you ask questions, you can increase the performance by 900%. And so I would be very cautious if you go out there and see ChatGPT can't do this or ChatGPT can't do that. Examples, because there were a huge slew of mathematics things that ChatGPT used to not be able to do that it can now do thanks to Google. Images, getting away from large language models, have also changed. And understanding what was inside an image was a very difficult task and was an active area of a lot of research. That is now considered solved. Meta put out a model called Segment Anything that just goes through the image and picks out every different thing that's inside of it and lets you basically go through and say whether you want that to be more granular or fine to your liking and deploy the model. So it's not perfect yet. Medical image segmentation still is the large challenge, and there's been a lot of research, and that's where the research is now actively in, taking all of that and moving it to radiology images. Finally, large language models are great for chat. And we've heard about vision today. I believe there have been announcements both from Google and from OpenAI for Bard and ChatGPT on them now having vision capabilities and enhanced vision capabilities as they're moving forward. But it's beyond that. A few weeks ago, there was a fundamental research that came out from Shanghai that showed the way to be able to allow the AI to understand all of the text, images, audio, diagrams, you name the medium, both as an input and an output using all the generative models we have in a very simple way, just taking all the work that had been done by others and putting it together so that the model in its internal mind understood these things. This is all happening now. Why am I telling you these things? And I'll take a pause for any questions on that. This is how fast the space is moving to me. Where any one of these things I think would have been a groundbreaking research in any other year, we have 4 now, and it's going faster because it's not just fundamental breakthroughs, it's the investment. We're seeing how great AI is, we're putting the money in, it's accelerating. That's what's coloring what I'm about to say, which is why I want to make sure that hopefully that was succinct and clear. Is there any questions, Mike, on your side or from the working group?
Sorry, I was on mute. I don't see any questions in chat, but please, if anybody wants to ask a question on this, and again, we're trying to frame this in the context of Wheaty's letter to Congress. And I think you have a couple of statements up here on the slide. Sorry, I'm just reviewing them right now. But so what about, where should we be, when we made our 20 recommendations to Congress? I see you have a statement up here. Do you want to address that?
And so sorry, Mike, I was putting that together so that these 2 statements I'm going to make sense.
Okay.
Because this is really the crux of it. When you now look at the recommendations, I think all 20 are fantastic, and many of them mimic what is being said by the other industry leaders, including the tech industry leaders. For example, putting out the nutritional guidelines for models has been put forth by IBM as well as an important thing that they think should be done. It's been endorsed by Sam Altman of OpenAI, the CEO, as well as I've mentioned here, Dario Amodei from Anthropic. And so when we look at the recommendations and the worries I have are the same 2 I have when I looked at the same statements to Congress from Sam Altman, which is these all make sense and they need to be done, but they need to be done carefully. And so I'm going to address 2 specifically. The creation of an AI oversight structure within the federal government, I fully agree with as a practitioner. I think it's going to happen. Everybody's asking for it. My concern is regulatory capture. And the issue and the concern I have for this is my knowledge that the vast majority of researchers in the AI space, and this is true in many, but to the extent that is different than any other science, is in industry. Almost every major advancement in AI is tied to industry. There's no large corpus of academic critical research. And so there's a high risk of regulatory capture because of that. And so I want to mention that that's the thing I'm most concerned about. While I believe this is important and needs to be done. My recommendation that I saw on number 3 that went along with this was an increase in funding for government research. And I think that's salient. I think that is the correct way through to be able to do this correctly and to have that oversight really work for the entire, healthcare industry. The second thing I noticed, and this is there was language about consistent definitions and consistent standards, and I think that's very important. And it's even more important given the space and the speed of the space. But I want to mention that it's not that these should just be established, but part of what that regulatory agency should be charged with is keeping those current and quickly adapting them. And this is now why I bring up all these advancements that are coming up. What are the definitions around AI agents? They didn't exist until February of this year. We need to know because they're starting to be applied today in systems. we don't have even amongst the different techs definitions, yet alone how this is going to affect people and affect people inside of healthcare. And so these are the things that I worry about when I see this is everything is I'm saying is yes, but also we need to, as we're putting up standards, as we're putting up definitions, we have to make sure that we can move at the pace that the research is moving. And if we do that, then I think this is going to be the exact way forward. But we just have to keep in mind that this is not going to be simple. This is going to be a needle that we have to thread. We're going to have to do this carefully and with purpose and with intent.
Well, thank you so much for your thoughtful review of WEDI's letter to Congress. It is what WEDI is, been created for, is we're advisors to the Secretary of Health and Human Services, and also we testify in Congress. And so would love for you to join us sometime in the future as we move forward working on our white paper, because I'd love to bring some of these thoughts and some of the things you taught us today into that. So I believe Congress is moving on this, so and WEDI is there to be that advisor, that a key advisor for them, bringing talented people and the diverse stakeholders across payers and health systems and standards development organizations. That's what we're here for. So would love for you to join us in the future, and thank you so much for your time. But let me just pause again if there's any questions from the membership. I see we have at least 9 folks on. Any questions for Demitri before we let him go back to creating amazing technology?
This is Rachel. I've been, following a lot of this AI, and particularly what's coming out of Mayo and Baltimore and Mass General and all of this AI is totally impressive. And what you've been talking about, Demitri, is impressive. The question that's coming to my mind is most of what I'm seeing now relates to clinical information. And we know how important that is, that we can get top-notch, high-speed, accurate clinical information so appropriate healthcare can be addressed. What about the administrative side in terms of how all this is going to get paid for? Who's going to pay for it? How is it going to be available in systems that payers and providers and others use at a cost that makes sense? And will it be uniform? So does that make any sense at all, Demitri?
That makes yeah, that makes sense. And I think all the pieces together really come to the salient question of this is happening, but if it's going to happen, how is it going to happen? But getting directly into payments and how that's going to be done, especially when you come to who's going to spend this, how are they going to apply it? I will answer all 3 quickly. It will not be uniform, and the rest of my answer will explain why. The payments typically will, what I've seen, really originate from plans, but what we see and what I've seen as these roll out is the payments usually are loaded, but these systems are always cost benefits. They always reduce costs, but usually by large amounts. And we're talking, medical care cost reductions that almost rival what you see from the APMs themselves when these are properly executed. And so the selling of these need to be in the systems is not a difficult piece, but the uniformity is going to be very challenging. And it's for 2 of the reasons you mentioned. One is the data, the clinical data is going to be the main driver. That's the main driver of all of AI, is the data. And healthcare, I will say, as a practitioner in the space, is a very interesting space because it's very easy if I am in a e-commerce website to see everything you've done on my website. The data and the importance that we put around, and the importance around things like interoperability in the healthcare industry, it's way different. Data is very hard to come by. Quality data, complete data, unbiased data is one of the biggest challenges I've seen in this space. And so the payments, I think, will come from the cost savings, and they will be instituted. It will not be uniform because everybody's clamoring for their own individual solutions. And it's tricky because it's hard for anybody who's not a practitioner in that particular space to know which of these solutions is better than others. And so I think we're going to see almost sort of what we saw in the .com era. We're going to have a lot of AI, and there's going to be a lot of benefits, but there's also going to be honest, a lot of silliness. And I hope we can reduce some of that.
Great question, Rachel. Thank you. And thank you for the comment, Erin. Enjoy CAQH Connect this week. But I think we're gonna wrap up, Sam, so you can close off the recording. Thank you so much. I mean, I do have to take some aspirin because that was a lot of information, but a lot of great real world examples. So thank you so much for your time.